But first and foremost, we are excited to have Ralph Norman with us today, the Congressman. We'll see him in just a few minutes, so we're very honored on that. Crystal, has invited Neil Collins. He is from the 5th District, representing Pickens County. Is that correct, Crystal? So he may be joining us if he hasn't.
Yes, ma'am.
He is driving, so from vacation, so he was going to try to log in. So that was very kind to him as well. He wanted to hear about the Accumulator Adjuster Program right from Colette. So this is awesome. So again, thank you all for joining us tonight. What an honor and what a privilege. And thank you for all being here, seeing all of you. Just a few housekeeping notes, as we are very well aware. We've got this, I think we got the Zoom thing down, very well. Just go ahead and keep yourself muted. Anytime that we want to ask questions, go ahead and put it in the chat. Jeremy, our policy and advocacy coordinator up there, is going to be looking at that, as well as Greg Whittle, the chapter's development and communications coordinator. So they'll be watching the chat. If there's something that you want to need to be, and actually I should probably ask you, Jake, do you think he would like, when he's speaking, do you think he would like, if there's something, a question that has been asked that's on that moment, do you think that he would like Greg and Jeremy to just kind of not necessarily interrupt them, but lightly let them know that they have a question, or do you think it'd be at the end? Which do you think?
I think he's more than happy with however y'all want it to play out.
Okay.
Very, very, very laid back Congressman. So
he's very kind.
Yeah.
Very easy to talk to. Okay, well, we'll just kind of, guys, if it's something that is really pertinent to what he just said, you might want to just kind of raise and say, hey, so-and-so wants to ask that question, or, wants you to elaborate on that or explain it better or whatever, if they had a specific question. So we'll go ahead and do that. Otherwise, we'll leave it in the chat till the end. And you guys can also ask your questions yourselves. So we'll just kind of play that by ear how it goes.
And I was going to say one thing, and if for some reason, if he has to get off or connection gets dropped or anything of that nature, feel free to, if you don't get your question in or in the chat, or it doesn't get answered by him, send it to my email and we can make sure to get whomever an answer. All right.
Perfect. Thank you so much. So again, we just want to welcome everybody. Congressman Ralph Norman's 5th District covers the counties of Cherokee, Chester, Fairfield, Kershaw, and let me know if I'm wrong, Lancaster, Lee, Union, York, and parts of Newberry, Spartanburg, and Sumter. And, that is a big district, so we're very proud that he's here. And we have about 81 of our own bleeding disorder members that are members of our chapter, that many of them are here tonight, but they have a bleeding disorder and they are actually in his district. And then we also know he has, I think it's he has in his district 678,000 constituents, from what we can, got from his page. And we know that there's an estimated 1 to 2% of the population can have von Willebrand's disease. So technically, he can have an extra 6,700 individuals, or if you went 2%, up to 13,000 people living with von Willebrand's disease in his own district. So what we're talking about tonight will, is personal. It's in his district, so he would love to hear about that. So on tonight's meeting, he's going to come on. When he comes on, we'll give him the floor. He's going to kind of talk about the lay of the land or what's happening in Congress and Washington and anything that affects South Carolina. So we're excited to hear. We know that there's a lot going on in Washington, and on our behalf, we want to thank him, everybody in South Carolina that's working to keep us all safe, number one, with COVID and everything that's happening, but also just for working on behalf of the people of this great nation. So thank you for that, and him taking the time out of his busy voting to come over and sit with us. So we're very proud of that and very excited that he would, and honored that he would do that for us. So tonight, you're going to hear from Kimberly Rasser. She is the Senior Manager for Policy and Advocacy for the Hemophilia Federation of America. She's representing all of our national organizations, kind of their collective message of the needs of the bleeding disorder community. So we thank Kimberly for being with us tonight. You're also going to hear from Nathan Schaefer. He's the Vice President of the Public Policy for NHF. And he's going to highlight briefly, we are part of a state-based coalition, very proud to be of a coalition with NHF. So he's going to kind of let everybody know what that is, of what we do. And then he's also going to then introduce Colette Koulianos. She is the Senior Director for Payers Relations for NHF. She's going to enlighten us on and really give a good presentation that's very easy to understand on the Accumulator Adjuster Program and how that affects our community with access to care. So we're very excited to have her. You're also going to hear from Cedric Jordan. He's our HSC board member. He's going to Limestone College. He's getting a business major. And he's going to kind of just give us a little bit of an understanding of what happens for those individuals that age out of Medicaid and they can't afford, or there's no place for them to go for insurance, or for some of our older adults that, you know, if they can't get into the marketplace and we didn't expand Medicaid, we do have a lack of how they can get services for insurance, and that's important to us. So he has a challenging situation that happened to him, and we asked him if he would just share that to know what we need to do better on our part to make sure that we help people that are aging out of Medicaid to understand where to go for resources if we have them. Crystal Day is going to be our last speaker. She's our Advocacy Coalition chair. She's a mother of an adult son with hemophilia, and her message basically is the need for access to prophylactic treatment. So first, before you hear from any of them, and we wait for the congressman for a minute, I'd just like to give everybody that is not familiar a little bit of information, kind of updated on Hemophilia of South Carolina, our Advocacy Coalition, and our ambassador program. Many who are here with us tonight, so thank you all for taking time out of your day and doing what we ask you to do and being a part of this program and raising your voices and being with us. So we currently at HSC serve about an estimated 1,000 members that comprises of 373 families in 42 out of the 46 counties in our state. We serve people with hemophilia A, hemophilia B, von Willebrand's disease, and we also have 11 other rare bleeding and platelet disorder patients and members in our chapter that we serve. We do serve the entire state of South Carolina, and we do have some members in North Carolina, Georgia, and all the way in Tennessee. Our Advocacy Coalition is comprised of 11 members and 13 affiliated national organizations and stakeholders, and 25 coalition ambassadors, many of you here tonight, who represent 13 counties. We are also a member of several state rare advocacy coalitions. Additionally, in Congress, I had already told you about this, in Congressman Norman's district, who I see he's here, so this is wonderful. Like I said, we have 81 of our own members in his district. So we're really excited that he took the time out to be with us tonight. So on that note, I do see him here. So if he is ready, I'm going to turn the floor over to Congressman Ralph Norman. Thank you so much for being with us. It was such an honor, and sorry you had to go vote and then come back and be with us, but thank you for being here. The floor is all yours.
Well, it's my honor to be here. Sorry for the delay. We never know, with Ms. Pelosi, we never know when we're going to be called back, but anyway, we got them through for tonight. No, thank you for having this Zoom meeting. I will always remember the group that came by my office who talked about the hemophilia and the effects of it, and it had an impact. And that's why I followed this and tried to help in any way. As far as the lay of the land, we have, I think, 26 more days to vote on different things. We've got, we still don't have a budget, but we've got, starting next week, the Defense Authorization Act. We've got other issues that people have raised. That today, it was infrastructure, CARES Act. We'll have a third round of CARES Act funding, PPP funding. Don't know what shape that'll take until we actually see it. As always, I tell any groups that come in that I believe in, and yours is one of them that I have a strong feeling about, to let your voices be heard, meet with your different congressmen, and I tell all the groups that, again, that I think are worthwhile to get with your congressman, whether it's Democrat or Republican, and tell your side of the story. It all starts with the conversation. And I appreciate what y'all have done. We've got issues, as y'all know, with the COVID virus has kind of altered our schedule. We have a good many congressmen that are voting by proxy. Each congressman has 10 votes that he can give. None of the Republicans are doing that. We're all showing up. We're here. I'm in the business arena. When you're getting paid, you go to work, and that's what I've always been taught. And hopefully, when the coronavirus goes, we'll get back to normal and do the work of the people. But I'll be happy to. That's kind of an overview. I'll be happy to go into any details or take questions from the panelists or anybody else, really.
You had mentioned the while you're on that, the PPP third round. Is that like another stimulus PPP packages for businesses? Is that what you're talking about? As a nonprofit, we did apply, and we thank you for that. It really is helping all of our nonprofits stay visible and stay afloat in this time. So appreciate that. I know my colleagues throughout the nation, it was a little hard. We've never had to do anything like that, but thank you for that. So is that what you're talking about? Another round of that possibly?
Another round. It's something, I won't be supporting because there is no piggy bank that was going to get this money. We're 28 trillion, $28 trillion in debt. And sooner or later, the piper is going to have to be paid. We need to find where the money's coming from and before any more spent. The best analogy that I heard was when the coronavirus hit and the rush when the businesses started shutting down, the rush to get funding was like building an airplane and taking off at the same time. Uh-huh. And so there are a lot of things that didn't get, that were just kind of put together, but the country was in trouble, and thank God we're slowly getting back up to operating. But yeah, they're talking about another phase of funding.
Okay, thank you. Does anybody else have any questions? I can't see.
Sue, am I allowed to ask a question? It's Carrie.
Of course.
Okay. So, and I'm not trying to be very direct, but this is something that I've been thinking about this week, because they were saying with a lot of the layoffs across the country that more people are having to take advantage of the healthcare exchanges and Obamacare, whereas obviously no one could have ever predicted that we'd be dealing with COVID and what's going on. So I just didn't know whether, and I'm assuming that you're a conservative and a Republican. So if you're not, it doesn't matter either way, but I just wanted to know if there are people that are reconsidering their thoughts on the exchanges, especially based on that, because this is a situation that we could have never foreseen, but oh my gosh, thank God those exchanges are there for a lot of people. Thank you.
No, great question. I am a strong conservative. I'm a Republican. Serve in Congress as I tell people, I was not elected to bankrupt the country. Obamacare just didn't work. We couldn't afford it. You couldn't pick your doctor. You couldn't, the cost of what we pay for healthcare. We know more about the TV we purchase than we do the healthcare coverage we purchase. You can't afford to get sick. And that's a shame. One of the things that I think has got to be on the top of anybody's agenda, really, and quite frankly, Republican and Democrat. But it's just we come from two total different universes on how to handle health care. I'm of the strong opinion government shouldn't run it. We ought to have competition. We ought to have sunlight. I'm working now on the PBMs, getting the pharmacy benefit managers exposed, and sunlight and letting people know what they're paying for is the best cure for our health care. We've got to get the doctors, who many are not staying in the practice and are leaving because of the red tape and the bureaucracy. Yet the Democrats want to continue to put Obamacare back in and let the government run it. I just am opposed to that. And you know, it's going to be, we don't have the votes now. As people, as you know, Ms. Pelosi controls all the committees that have the votes. So it won't be done in this session, but hopefully next session after November 3rd, we can put some business reforms in place that'll let us shop our plans. Let us see what we're paying for. And, you know, I'm a real estate developer. I mean, I know what business, I know what burden it puts on our company and for the consumer as well. That's a long way. Sorry to be so long-winded on that.
This is Renita. I have a quick question. And I'm in York County. So you mentioned that the Obamacare, actually it's the Affordable Care Act, right? So with that, you're saying not working. What is in place? I mean, I know you said you're not for it. So what is in place that is going to work, right, with the health care? What do you all have in place? So what is it that you have on the floor now that's going to work?
Great question. In York County, you're in a great county. I know it very well. No, I think that's the big question. What plan would we have if we do take back control of the House? Right now, the plan for the Democrats is more of the same. More of the same of Obamacare or the Affordable Care Act. And it hasn't worked. Try getting sick. You know, the deductibles have been going up ever since it's been in place. There's not you know, you look at Medicaid, you look at Medicare, you know, people think just Social Security is going bankrupt. It's Medicaid, Medicare as well. So this has got to be our ultimate plan for our health care is to let the patient choose his plan, to get rid of as many, I guess, mandatory coverages. Let the patient decide what care he wants to pay for. As an example, we're still on our company plan, we're having to pay for OBGYN care. I'm sorry, I don't need OBGYN coverage. And a lot of them need to be able to craft their plan. Secondly, you need to buy from, and this is my ideas, be able to buy across state lines to choose your insurance company, as you do for your car. If you buy a car in York County, you can get insurance from any agent that you want. And thirdly, we've got to know what we're paying for our pharmacy drugs. We got to know when we get the hospital bill, tell me who can understand the billing. I can't, and very few other people that get sick can. So we got to break that down where it's transparent, I guess is the best way to say it. Government, though, which is Affordable Care Act, is not the answer. We tried it for 8 years and it hasn't worked and not going to work.
So let me ask you this. You said that you don't need OB/GYN. So are you married, or do you have girls? Do you have daughters?
I'm married. I've got 4 children. I've got 17 grandchildren.
Okay, so do you think any of those women would need OB/GYN?
Yeah, but the difference is yes, they do, and they can choose that. You ought to go down just like you on a grocery. When you go to a grocery store, you choose what you want to buy. If you want to buy groceries, if you want to buy meat, you choose. You're the ultimate decider. And that's not true now. You're forced into coverage on so many of these issues. I'm just opposed to that. It doesn't make financial sense for you, and it doesn't make financial sense to the doctors who are having to cover everything in the world. And I'll tell you another thing with try asking any OBGYN physician what he pays for lawsuit protection. In other words, they're getting sued for everything under the sun. That's not fair. You know who's ultimately paying the bill? You and I are. So we've got to get it back. That's why I let the patient decide, and we've got to try to find solutions to it.
Right, and so far we don't have a solution. Would that be correct? I mean, we had it for 8 years, the Affordable Care Act. So, and I'm just trying to understand because doesn't seem like the question was answered. I'm asking, like, so what is in place, right? It doesn't sound like anything is in place that's going to be better than the Affordable Care Act. I mean, if it's been 8 years now and nothing has been taking that out to put something else in place. I'm just wondering what do they have in line?
Under the present leadership
Mm-hmm.
of the Democrats, they want to keep what's in place, Obamacare, Affordable Care Act, which is government-run healthcare. That's what's their vision of what's in place. What I'm trying to explain, I disagree with that. I think it ought to be just what I went over. And so, yes, what would be in place if we had the support of the votes would be far different than what you see now.
Okay, so you don't have the votes to put in place what the Republicans or the government that we have right now in place. You don't have that, is what you're saying. You don't have that vote to get what you would like in place.
Right. Just what I mentioned. If I put that on a piece of paper and put it before the 435 members of the House, no, we would not have the votes, nor could we get it through committee to hopefully make it law.
Okay. Thank you.
I have a question. My name is Dawn Pfeiffer. Would any reform that they would put in place if they did have the votes include the important protections such as pre-existing and lifetime caps? Because I, for one, could not get insurance prior to the Affordable Care Act. And my family went bankrupt paying medical bills. So I have a lot of health issues, including the bleeding disorder. And I need to know that I will be able to purchase the insurance, because before they turned me down and said that I couldn't purchase it and I could purchase from the pool, which didn't cover anything and was very expensive and it just wasn't reasonable for my family. So will reforms include something in place of the Obamacare?
Any reform, and this is a good thing, and I think really whether it's a Democratic or a Republican reform, any reform will have coverage for pre-existing conditions. And I think what the form that would take is yet to be seen, but you would have a combination of a separate fund that you pay into to cover those. Patients who get cancer don't have a choice to get it or not get it, and they need to be taken care of. And just what you're talking about, as well as a lot of other diseases, has to be covered. And I think, and it will be covered, or it will never pass the House.
Don't mind. My name is Colette Koulianos. I'm with the National Hemophilia Foundation, and I'm also conservative, but I think I like to separate healthcare from politics, because being in healthcare, there's some fundamental facts that I just challenge you to think about. When, the comment about pregnancy, I agree you're not going to get pregnant, so why should you have OBGYN coverage? But males and females are both part of that equation, right? I think that was the point. And I don't have kids in school, but I pay my property taxes for schools and parks. And I think some of the challenges with trying to mix politics and healthcare is that we might not give enough consideration to some of these other points I think that maybe they're making. But in the healthcare, in the chronic disease world, and we know that more than 25% of the population has at least one chronic disease, you're right, they don't ask for it in many cases. And a lot of these things are being impacted today. So I think we can all agree on that part, at least.
Yeah, and let me say this, the difference, and you just mentioned about, you pay for parks and you pay for other things. You vote on the representative that you put in office, whether it's on a local, state, or national level, that you vote for the individual things you just mentioned. Now, my view is that you ought to be able to choose. If you and your husband have no children, you pick the plan that suits you. And if it's not having children, why should you have to pay for? One size doesn't fit all in healthcare. One size doesn't fit all in a lot of the things we vote on. We try to lump it in. And as far as politics being involved, it's two different worldviews. You've got one group with the Democrats that think government can do it better. And you have those of us on the conservative side. I disagree with that. And so I think to that end, we try to have a middle ground. But I will tell you, it's polarized now. But healthcare, one thing we all can agree on, healthcare, we've got to find a solution to. You're in the healthcare business. We need to have a consortium of doctors, of nurses, people that are on the, that have boots on the ground. And we haven't done that. We tried to rule by fiat from Congress. And in Congress, I would say this, a lot of times we don't know what we don't know. And that's why we've got to come up with an answer, because anybody that gets sick, that pays the bills, and you ultimately pay the bill, whether it's through premiums or whether it's through out of pocket. And so that's one of the things I'm very interested in. And because I paid those outrageous bills. One thing I know, the Affordable Care Act is not working. Anybody that can tell you it does, give me an example of where it is working.
So on that note,
from a medical standpoint, or from a cost standpoint, I know a lot of the hospitals in some of the larger inner city areas have for the first time operated in the black, because they have, insured patients as opposed to folks that come in uninsured, which then the federal government still steps in and bails those institutions out, I think, in the end. I'm not saying we have a perfect system by any means, and I'm not challenging you. I'm simply saying sometimes I think the business of healthcare, it's not black and white. And when I would choose a plan, when I did have my children many years ago and I chose a health plan, the cost of maternity coverage, for example, made some cases unaffordable. And so for our community, having essential health benefits like were mentioned, pre-existing conditions, lifetime caps, they're part of that package of 10. So if any of that's broken up without some other definition being put in there, it could be eliminated in even just one state, especially with ASO plans, self-funded insurance plans. If one state were to eliminate the essential health benefits in all of them, or decided they were going to eliminate pre-existing caps because it comes in that package of 10. So then what happens is any ASO company, whether they have employees in that state or whether they have a physical location, could choose that to emulate their plan off of. And then we could have all the self-funded employers now who don't have any of those protections as well. So it's just purely from a healthcare business standpoint, that's the concern that we have, and especially for our population, which, it's life and death, having coverage and being able to access their medications.
And I agree with you 100%. That's why we got to get it right. And we got to change what's not working. And I wish we could take the politics out of it, but how do you, you tell me how I convince somebody that thinks that government can just do everything better. We've actually I'm on the budget committee.
I agree.
I'm on the budget committee. We actually had the comments and I had a McDonald's franchise owner. We had a group that just feels like government should run our McDonald's, our Burger King. That's how polarized we are now. So, take the good side about having this discussion, take note and ask difficult questions on which side of the fence people are leaning with healthcare, with getting this country out of debt, with our military. It's a complicated issue now, but there's no better time to get involved than now.
Mm-hmm.
Thank you. And on that note, let's go ahead and go to Kimberly, because I think what we're having the conversations of what's important for our community, so that you have an understanding of some of the things that we are dealing with. And obviously, we do need to get it right. We need to work together and find some solutions. So if I can ask Kimberly, she kind of speaks for the bleeding disorder community nationally, what's important for us to be able to have quality of life and have access to insurance. And I think that's where it's difficult for us, because we do know without it, it's deadly and very detrimental to our community. So Kimberly, you want to chime in here and give us kind of an understanding of what the bleeding disorder community needs?
Yeah, so well, first of all, I want to say thank you for allowing me to join you guys tonight. And thank you, Representative Norman, for being on the call with us. Like Sue said, my name is Kimberly Ramsour. I work on the policy and advocacy team with the Hemophilia Federation of America. And so while our office is based in DC, many of us work remotely. So I am actually not too far away from you guys. I'm next door in North Carolina. But so I'm very familiar with South Carolina. as your neighbor. But one of the things that I did want to talk about tonight is some general needs for the bleeding disorders community. And so while many of us are different in the things that we need from the healthcare system, there are some things that we do agree on as general requests when we are discussing our healthcare needs. And so one, we did already start this conversation, a working healthcare system. What that looks like, you know, no one really has a clear-cut answer, but we know the things that we specifically need within our community, and namely access to treatments and care. And so depending on whether you have hemophilia or von Willebrand's, you need access to treatment and care that can not only be life-saving, but also prevent a lot of bodily injury going forward. And oftentimes we have barriers like step therapy protocols that are put into place to prohibit patients from getting access to the medications and treatments that they need as prescribed by their physicians. So there have been legislation on both the state and federal level that have tried to, you know, on several occasions been passed, but we are looking for federal protections that will cover all states that will prevent step therapy protocols being put in place to prevent a lot of our community members from getting access to life-saving treatments. The other things that we need is good, comprehensive, quality, and affordable health insurance coverage, as we already have been talking about. And so again, what it looks like, we don't have the exact answers yet, but we are excited and look forward to being a part of the conversation going forward. Other things include protections against high out-of-pocket health expenses. And so as you'll hear later on tonight by Colette, she'll talk about the Accumulator Adjuster Programs and get more in depth into that. And then some things like high deductibles, high co-pays, and even surprise medical bills, which many of us have had to deal with from time and time again, no matter where you are in the healthcare system. And so, you know, for our community, a lot of times, you know, when you go to look for a health insurance package, you know, oftentimes people want to get the plan that is going to be least when you're paying your premiums, but you don't understand that you're going to end up paying like a high deductible before you get access to all the benefits in your plan. And so we're looking for protections that prevent that. And also access to safe treatments and blood product safety. If you are familiar with the bleeding disorders community, a lot of our advocacy really comes from the HIV/AIDS crisis, when a lot of our members were infused with tainted blood products. And so we want to continue those protections, but also as we have newer pharmaceutical products that are coming out to market, making sure that those products can get to our community, but also be safe and effective going forward. So that's just a high overview of some of the issues that we are, as a whole, are advocating for our members. I'm happy to answer any questions or go in depth more if need be.
Yeah, Kimberly, here's what I need from y'all, and thank you for your work. As I mentioned at the beginning of the program, your group was as impactful as any group that's come to Washington to meet with me, because you just feel for the people that came here that had hemophilia and were suffering with a disease that was no fault of their own. Here's what I need though. I mean, you covered some broad topics, you know, lower insurance costs, lower deductibles. Here's what I need you to do to make it real to sell on Capitol Hill. Break down, and you're in a perfect position to do this because you've been doing this, and it all comes down to breaking down a patient that you're seeing, break down the blood problems and blood treatment. Take a couple and break down what they're paying for each individual for their plan on the insurance side, and then on their plan for the pharmaceuticals. And just look and compare and ask, what's out of line? Where do we specifically need to drill down to try to get a handle on a disease that desperately needs coverage from the federal government? But I could tell you, we've got so many programs that have never been sunsetted that are really an abomination to this country, on dollars that are going places that it shouldn't go. you know where, or you can find where programs that are in your field or in your realm and say, this is outdated, it should be cut, this is where I can find the money. So, because when I go to that budget committee, I can say, here's some of the things we need to look at, and here's where we can pay for it by programs that should have been sunsetted and done away with years ago. And I just need you to break down those things for me. And we take it seriously here because, again, you know, the patients that I've seen that have come by to see me have a need. And but we got to break it down. What you had was big, but it boils down to an individual patient who is suffering from that particular disease and where the inefficiencies and the overcharging is, I guess is the best word I know to say it.
Thank you. We will get that done. Right, team? We can break that down.
Yes.
And Jake, and let me Kimberly, Jake Hilkin's email is on there. And let me give y'all my cell phone so that I'm happy to take any calls anytime. We really do take this seriously. My cell phone is 803-242-4558. That's this phone right here. I answer it, and it may take me a while. I've got 25,000 emails, but my calls, I try to get back within as quickly as I can. But help us solve this problem. It's not going to be done by bickering and by pointing fingers. It's going to be done on the local level, just what I mentioned. Get each patient saying, these are my problems. This is why it's not working. And what can we do about it to find a solution?
I hear you. All right, so let's hear from Nathan. Nathan, and then introduce Colette in the problem with the accumulated adjuster. I think you'll probably understand this pretty well. Nathan?
Yeah, thank you. So I'm Nathan Schaefer. I'm the Vice President of Public Policy for the National Hemophilia Foundation. And Sue wanted me to just talk a little bit about our state advocacy efforts. We have a program at NHF called our State-Based Advocacy Coalition, our SBAC program. And South Carolina, I'm proud to say, has grown as part of the program in recent years in very, very significant ways. So we've got chapters in almost every state in the country, and we encourage them not only to go to our annual Washington Days, but to also participate in state and local advocacy efforts. South Carolina this year in early March, you got a state advocacy day in just before everything went down with the coronavirus. The vast majority of states had to do virtual advocacy days, but I was able to be there and participate with all of you in early March, which was a pleasure. We do that in at least 30 states in a normal year. This is not a normal year. But in addition to that, Sue mentioned about your advocacy committee, and you all have an advocacy ambassador program. This is something that we really encourage chapters to consider, identifying community leaders who are volunteer advocates that can carry out a lot of your advocacy initiatives. Sue doesn't have a lot of staff at the chapter, so she can't do it all on her own, but she's got empowered, amazing community members. And one of the things that I appreciate about the way you all pursue, like, who do we have at the table and who do we need at the table? Sue's always looking at, okay, if we look at every congressional district, do we have somebody in each of those that is a reliable advocate? So I just give that to you as an indication of the sophistication of your state and local advocacy initiatives, because you're really head and shoulders above so many other states that are much more populated than South Carolina. So we've been really proud. You've been part of the SBAC program now for, I think, 4 years and have really grown immensely. And so I want to thank all of you for lending your expertise. There are a couple of my colleagues who also work in state government relations that are listening in tonight, because just to sort of see how this conversation was going to go. So that's a little bit about our state advocacy efforts. We have a presence everywhere we can. We work with everybody on every side of the aisle, and we try and find as many community advocates and empower them to grow their advocacy skills. And you've all done an amazing job of that. So with that, I'm going to introduce my colleague, Colette Koulianos. Colette is our Senior Director of Payer Relations at NHF. She also, before she came to work for us, she ran a hemophilia treatment center. So she's got some sophisticated experience about how you manage getting clotting factor out to the patients that need it, and how do you do that most efficiently in the most cost-effective way possible. But what she's really taken on in the past couple of years is this issue of accumulator adjusters. And I'm here to tell you that Colette is really the expert across the country for how these accumulators affect bleeding disorder patients. And she's been able to use that experience to inform other patient advocacy organizations. She's provided testimony at I don't know how many state houses at this point, because we've seen a lot of action at the state level as it pertains to accumulator adjusters. So with that, I will say thank you for having me on tonight. It's a pleasure to work with all of you. And I'm going to turn it over to Colette.
Hey, Nathan, can I say one thing?
Sure.
Just like I was asking Kimberly, you know, South Carolina has done well, but we can do so much better, and do the same things that I suggested Kimberly do.
Yes.
As you advocate, bring it down to the local level. Let us know on an individual level where you have examples, what's not working. And Colette, I'm sure, can tell me what's not working in her field, accumulated adjuster program. But just let's break it down to a local level, because we're getting bombarded with everything.
Yeah.
Particularly with the COVID virus. Tell me one business that's not suffering. The budget cuts that are coming our way are going to be horrendous, and it's going to take years to get out of this. So help us, because y'all would be I'll be honest with you, you would be the first one for the funding to get cut. Unfortunately, because other groups, you know, that have been on the books for a long time are not going to be looked at, and they should be. So help us on that, and let us try to help you.
I'm hearing you say we need to have a very large voice to make sure that we don't get those cuts, correct?
Absolutely, and you've got to have a voice, and you've got to have, just like when you came to visit my office, I actually saw the patients and saw the people that were afflicted with it. That's what you need to do. But then you've got to carry it one step further. Just like it's not going to work just to say you need to cut insurance premiums. Well, where? I mean, in what you do, and you know, where should I have them cut? And just like I mentioned to Colette, I mean, she's in the medical field. Tell me specifically, as she's gone around the country, what has not worked and what has worked.
Thank you.
Well, thank you so much, Nathan, for the introduction, and Congressman, for your time. There's a couple things you've said that I love. I love the fact that you're taking a deeper dive into transparency issues related to PBMs, and I'm sure otherwise in the medical field. I think that that's where we have to start in order to affect change. I would say that my experience in the past, having run the Hemophilia Treatment Center, before that a cancer center, and then my role here at the National Hemophilia Foundation level, is being able to utilize my previous roles to see kind of a fuller picture. And I have a lot of not only suggestions that are off the top of the cuff, but things I go around, not just on legislative issues, but I work with payers all across the country, mostly self-funded jumbo health plans, some of the largest companies in our country. And I help them look at their claims data and find ways to drive savings, and from hundreds of thousands to millions, sometimes even for a patient, one patient. So I agree that we have to not just say this, in the big picture pie in the sky, we need to do this. We actually have to show how to do it. And I'm more than happy to have further conversations with you on some of my experiences in the PBM world, but with specialty drugs, and where a lot of egregious costs are hidden under opacity that is several layers thick. So again, that might be for another conversation. I'm just throwing it out there that I'd be happy to have that dialogue.
Colette, that's just what I need.
Yeah.
Particularly on the PBMs.
Yeah. Oh, I have a lot of I call it well, useful for me and probably you, but maybe for others useless, but a lot of ideas and examples.
You've got real live experience. That's what I need. I need to see what's working, what's not working. You know, the first thing that hit me when I started looking, and we had a panel discussion on PBMs. You know, the first thing I started getting calls on?
Which?
People started calling, Norman, you're barking up the wrong tree. The PBMs have lobbies that are going to cut all this money from you. And I can't tell you to even look into it. That's what blows my mind, to even look into it. That shows me you got to look into it.
Yeah.
And so let's have the debate.
I'm glad you just said that. I love it. Thank you. Honestly, I mean that from the bottom of my heart. That's music to my ears. And that's really the fundamental thing with the accumulators. When we first saw in 2016, a patient reached out and notified us at the National Hemophilia Foundation that they were given their plan changes for the next coming year, which was 2017, and that in the plan changes it identified that they could no longer use copay assistance to help meet their out-of-pocket costs. So they said, they're telling us I can use assistance, but it isn't going to count to my out-of-pocket.
Right, yeah.
And I said, well, that it doesn't make sense. Send me your plan. And I did. And it was the first we'd seen anything on it. Literally not one thing on the web, nowhere in the country could you find information on this. We literally saw the very first self-funded employer who rolled this out. From then, it's, of course, it's proliferated and it's a very widely used program. But the premise is, if I'm the PBM, because that's who promotes these, the premise by the PBMs is you, the payer, whoever that is, you the payer, the company, you the payer, the self-funded plan, you're paying more for drug prices because of these programs, because patients are using assistance to help meet their out-of-pocket costs and so they get the higher cost drugs instead of the generics. Well, in theory, when we're talking about drugs that have coupons, like the stuff you see in your Sunday flyer, whether it's Crestor or whether it's Rosuvastatin, we're not talking about those drugs. We're talking about especially drugs that have no generics. And they're all high cost in the hemophilia world. And every one of the products has assistance available. So therefore, it's not a program that pushes patients to higher cost drugs. They're all high cost specialty drugs. Is that a problem fundamentally? Of course it is. That's not the issue, but there are a lot of layers to that, and I'm happy to get into it another time. But so that's the answer. The PBM said, so what we'll do is we'll roll out these copay accumulator adjustment programs, and we will say, you can use these assistance dollars, but that doesn't count to your out-of-pocket responsibility. And the way we can manage that is you're gonna have to sign an exclusive specialty pharmacy arrangement with our, they don't say this part, I add it, our wholly owned for-profit specialty pharmacy, because they own all those too, right? So it's a way to get exclusive contracts. So so a large part payers jumped on this. Really? I mean, patients are using these cards to meet their out-of-pocket. Let's do this. So they get the exclusivity. What the payers don't know, I've been on the call with these patients across the country that are unable to access their medications as a result. And those same PBMs are teaching patients how to circumvent it to get the drugs anyway. So they only used it as a ploy to get the program in. I promise you it's not netting the results that are being promoted. So they say to the patient, you can't use the card. So in the case of hemophilia, a patient is gonna have, our average adult patient with hemophilia is gonna cost upwards of $250,000 or more a year. The majority of that is their medication. And from month one, January, first day of the year, every year, when it's time to, the new plan year rolls around, it's time to get their medication. The cost of the very first month fill is going to far exceed the highest deductible right now set by the Affordable Care Act, which is $8,150. That's the max out of pocket. So right away, every year, every single year, year after year, patients with hemophilia, and not just hemophilia, a lot of chronic diseases, their drug costs, they're going to hit that full amount every year, month one. So in the past, they've been able to utilize assistance dollars to help meet that out of pocket and access their life-saving treatments. Now, if we use an example of a member who has one of these programs, let's say their out of pocket is $5,000, we're going to make it simple. and they have a coupon card or a assistance dollars worth $15,000. They're going to get to use those dollars January, February, March. Now they've exhausted the assistance. Come April, where that cliff happens, the patient either has to have $5,000 or they don't get their medication. That's it.
That's sick.
It is.
And
that's exactly what's happening in our country, and it's happening at an alarming speed. And the sad truth is, patients, you know, healthcare literacy in our country is low. The average American, they say about 9% understand basic healthcare terms. So we're talking about premium, copay, coinsurance, deductible, and out of pocket. And I would challenge that number's probably not that high, because when I sit in an audience and everybody's, no, I understand it, and then I start asking questions, the numbers, they dwindle, what the real understanding is. So the premium is what you pay to get your insurance. And you're right, we have issues with premiums, whole nother discussion, but the premium is what you pay to get the insurance. And then, so that's a certain percentage of the dollar that the American people pay for their insurance. Now, if it's employer-sponsored insurance, that means their company's paying a certain portion of that premium and they're paying a portion. But then after, they have to meet first the deductible, because if you have a deductible on your plan, you have to pay 100% of your deductible before the plan pays the first penny. And then you have co-insurance and co-pays until you hit your max out of pocket. So we have a problem with understanding what those terms mean. So when patients are left with the choice of what plan to pick, it's hard for them to understand even that, let alone anything further. So these accumulator adjustment programs were rolled out, and they have very clever names, Congressman. They have names like copay maximum benefit protection program. That's United Healthcare's term for this. And all kinds of clever little names that the PBMs have given to these programs. And so patients get notified that they got this protection benefit, and they think it's a good thing. They have no idea, you know, the disaster that's looming. And so, as I mentioned, they get the card, they utilize the assistance until it runs out, and then they're left with the full amount. We hear our proponents for these programs, the PBMs say, well, listen, patients can save their money in their HSA. If it's a high deductible health plan, which is the ones most affected by these programs, they can put the money in the HSA pre-tax. Well, the most you can save as an American for an individual every year is $3,550, right? And so, but the out-of-pocket max is $8,150. And every year in January, they're going to have that $8,150 cost, or whatever that number is going to be next year. And the HSA, if they, in a perfect world, everybody could save the full HSA amount, we didn't have any financial barriers to that, that's still only $3,550, and it's only available as you put the money in. So in January, after your first check, if you're paid biweekly, you might have $137 in your account. That's not going to pay your $8,000, so you're not getting your medicine. So what's happening is patients across the country, left unable to get their life-saving treatments, are forced to go to the hospitals and ERs, which is 10 times more costly to access these medications than if they could just get it. So the plan thinks they're saving money, but they're paying more on the back end for these other options. So these are the fundamental problems. And then I'm looking at like your numbers in South Carolina, specifically in your district, and your median age is 40.3 years. Is that what, hopefully that's a number you know and have. 60% of the people in your district range from 18 to 64. So that's, you know, that's the majority of the folks in your district. And the median per capita income is $28,000 in your district, and the median household income is $52,045. So out of that household income comes living expenses, house, car, kids, clothes, all of that, and the premium before they even get to talk about the out-of-pocket costs. So the math doesn't compute, unfortunately, a lot for our population and other folks with chronic rare diseases that struggle year after year. And so, you know, for them, these assistance dollars were a lifeline to being able to access their treatments. And you mentioned deductibles, you know, and that is a problem. And deductibles rise in our country. The average deductible in 2020 is is $4,292, and that's for your deductible. That's the average, and the average out of pocket is in 2020 $7,776. So here's where the problem lies. 3 out of 4 Americans don't have enough money in case of a $500 emergency, let alone to meet these type of expenses. And then you have the collision of copay accumulators and COVID, right? And where the collision happens is a huge catastrophe for our population. And so, the unemployment numbers, I know in South Carolina are no different than everywhere else in the country. They're rising. In South Carolina, folks who lose their employment don't have Medicaid expansion. Their option is the marketplace. Left without the knowledge of even understanding how these programs work, the choice is likely going to be, if they go on the marketplace, is going to be to pick the lowest premium, and the lowest premium is going to mean the highest out-of-pocket costs. And unbeknownst to them, here's where these programs sit, and that's where the problem lies. So I'm happy to answer any more questions.
Let me just say this, Colette. One, on the PBMs, I'd love for you to come to a group meeting of physicians, of people who have a real interest, pharmacies, and we've asked to get the contracts of PBM signed, which try getting one. We're going to get them.
Yeah, good luck.
Monopolies don't work.
They don't work.
I'm a real estate developer. If you only have to choose for me to build your shopping center, you're going to pay a high price. You need you need competition. So my issue is, what I'd ask you to do is get Jake just what you've told me, because you're right. The acronyms that are used in the medical world, they're done for a reason, to keep people confused. We're customers. We're paying the bills. I hate to see people say, well, your HSAs are paid by the business. No, that raise that employee should have gotten is going to pay health care. You're paying it. So help us. I need to know the pitfalls that you see, and I need to know what, in your opinion, is going to take to fix it. I'm tired of, up in Washington, the most outrageous comment I always get: let's have a meeting to have another meeting. I'm tired of it. It's time to come with solutions and vote it up or down. So help us on this. You know what these groups, the monopolies, hate to see, and this is where the people have the power, is sunlight exposing it.
They absolutely hate
because they cannot back it up. And so in the world I'm in, if I build your house and we have a problem, I go to the carpenter that put it together. And we're going to go to the base of the PBMs, and we're going to expose it. And if they can't explain it, guess what? That's their problem. So help us do that. Send us your contacts. You've got my cell. Let me know, because I would love to tap into your knowledge. And the IQ among politicians on the acronyms in medicine, it's less than 3%. So we have to get educated.
All right. I'll put the acronym list together.
Okay. Thank you.
Thank you, Colette. It's great. Her knowledge is unbelievable. And you would be, I can tell you, all of you, if you can have her sitting in the room, I know she meets with some of the biggest and the best, and she can just lay it out there, and let's find a solution. I'm with you. We need to find a solution, because these things do affect our community. And for us, what happens is I get the back end where people come to us and they don't have their medicine. And what we do know is when we can't afford it, our members go to the ER room. And at the ER room, when you are using a high dollar amount, they're going to do the best that they can for you. But a lot of times then you're sent back home, and the complications compound, and then they're back in. So no matter what happens, it costs our state more money when our patients go to the emergency rooms. And my role and my goal is to find solutions so that we have affordable care, so that they have whatever they need to get their product. Because once we do know, you'll hear from Cedric up next, and then we'll close with Crystal. When patients when they're born, I have 3 sons with hemophilia, I can guarantee you when we have what we need, they live a pretty decent life. When they don't and the damage starts to go, that's when it's not just a physical, it's a mental, it's economical, and it is just a spiral downhill. And it doesn't need to be that way if we can find solutions.
Get this. I got a call from, I think, a lady, she probably was 40, husband died, had her 2 girls, one developed severe diabetes. Now, diabetes just didn't develop yesterday. Insulin did not come on the market yesterday. It's been around for, what, 40, 50 years. She said, I can't afford the insulin. He said, what am I going to do? And that's a shame. I mean, that's why we've got to find a solution. And that's where insulin paying outrageous. Now, she eventually, it's just what Colette said, she beat the system, not in a bad way. They weren't going to donate. If they could get the high price, they were going to get it. That's where we've got to find out. And the same thing with hemophilia. We've got to get, it's not that complicated. It's just about somebody having the time and the diligence to get the experts in to learn. And again, as has been said, get the politics out of it. Let's let the common sense hopefully will rule, and that we can come up with a solution.
Thank you. All right, Cedric, moving along. Oh, there you are. Cedric, I'd like you to share with our group a little bit of what happened to you, just so that we can see the side of where we need to do a better job ourselves, even at the state level of educating the community on rolling out a Medicaid, because we aren't a Medicaid expansion state. And he's such a great guy, and his situation is heartbreaking for me as a mother. I look at him as a son, and I think the burdens that he has, the financial burdens, should not be on him. And somewhere we've got to fix the solution. So Cedric, go ahead and tell me your story real quick.
It's Cedric. Can I mention, I've got a group waiting on me, and I'd love to have another meet. Go ahead and tell us, but if you could do it kind of briefly, I've got people I've got to go meet, but go ahead.
Yes.
I want to hear you.
Okay.
Thank you.
Okay. So what had happened was, after I turned 18, as you know, I was just about to graduate from high school, and I didn't know much about insurance. And the person that was basically taking care of my insurance, which was my grandma, she passed away. And so I was left alone to find out about insurance and how should I go about with getting insurance for my medicine, because I know that I needed it. And so after she passed away, that's when basically my Medicaid cut off, and I could no longer get the medicine that I needed, because they said that without insurance that I won't be able to even afford even a box of medicine. So I was left alone, I say, for almost the whole month of August without medicine. And so what had happened was, I was trying to research different insurance companies and trying to find different people that could help me get medicine. And luckily, Blue Cross Blue Shield, they could take care of that. And they said that they would be able to get the medicine that I needed. But I would have to pay a high premium deductible and all that. And so, but it wouldn't, my insurance wouldn't take place until the first month of the next month. And so I would be left without medicine for the whole month of August. And so one of my nurses at the hospital told me that if I needed factor, that I could come into the hospital. And she didn't tell me that there would be a cost or a bill or anything over my head. And so I was trying to, as much as I can. So right now I take about 1 dosage every 3 days. Back then I was trying to take 1 dosage every 4 to 5 days to stretch it out as much as I can. And so my aunt found out about this, and so she made me, well, she didn't make me, she had me go to the hospital, and she took me to the hospital so that I can receive the factor. And so as soon as I got there, I got the factor, and basically after I received the factor a couple of days later, there was an email sent to me saying that I have a bill, which was $18,000 that I had to pay. But luckily they said they cut it in half to $9,000. So as of this day, I'm still paying that $9,000 bill off.
See, in cases like yours, that's why that's, you know, $18,000. Who can afford to pay that? Only the ones that have got that kind of money. And again, this is something you didn't get this by any choice that you made. And I would add that, you know, the sad part for patients, when you go into the emergency room, you don't get the care, specific care that like hemophilia and other things that require specific doctor's care. You just rushed in and rushed out. That's why we got to solve this problem.
Perfect. Thank you, Cedric. Well, I know that you need to go. So Crystal, just say goodbye and let him get on with his meeting and his everything, but just share the last few moments with Congressman, please.
Okay. First of all, thank you so much for doing this. My story will be just super quick. I was one of those, my dad passed away due to the tainted blood with AIDS, and I have a son who's 22, and the difference in his life in the last 4 years is access to care, is getting his medicine. We were at the hospital probably 4 days a week, all growing up. He missed so many days from school. His ankles are destroyed. But once he could get his actual infusions and just get the infusions inside of him and control the bleeding, my son has not missed a day of school. He went to Clemson. He didn't miss a day at Clemson. He actually was disabled, but he chose to get off a disability at age 18 so that he could get a job and be a productive member. He still is damaged, but he's working now because he has his medicine, and it's preventing, you know, these extra bleeds or whatever, and we're not spending astronomical amounts of money. I mean, I'm shot with the money. I mean, with all the bills and stuff, my credit's ruined. Well, now he's 22, and if like poor Cedric said, you get those bills. Why should my 22-year-old, you know, he can't have $9,000 to pay for anything, but having access to care, my son's not been, knock on wood, he's not been in the hospital in 4 years. And I have never been able to say that forever. He was always in the hospital. So many times it's ridiculous. I mean, but just by him getting to have the factor that he needs, and every factor is different. Unfortunately, we don't have generic medicine, but getting that, it's not costing anybody else more money, if that makes sense. He's not on Medicaid. He's not having to have all these extra things. We're not having hospital bills, but he's getting the treatment he needs, and he's living a productive life. So
yeah, am I able to say one thing? Because I think that's a perfect ending for me to say, and that's exactly why missing even that, when that cliff happens and these copay accumulators don't allow patients to access their meds, and you heard Cedric say it when he couldn't get the meds for a month, it may not sound like that big of a deal. And it might not be if it was acne medicine or something else, but this is life and death stuff. And even having one untreated bleed can lead to permanent, lifelong joint damage and arthropathy and terrible pain. And so as she said, because her son had that period, he's now got these, you know, disabilities. He's not allowing it to stop him from his ability, which I love to hear. But this is there should never be a barrier to access when it comes to a hemophilia patient, and these programs are the barrier. So I wanted to end it with that because I thought that was a great ending to add. And
the sad part about it, Colette, how many people are we missing out?
Oh,
Cedric had an aunt to come in. You know, that's why you have to work on it.
Yep. Right. And working together to find this, I mean, like you said, we got to throw the politics out of it. I mean, yeah, we want to be your source of information, whatever you need, but we just need, it's simple. We need the medicine. Unfortunately, you know, if we get it, the costs go down, our kids can live productive lives. I mean, I almost don't even know my son has it half the time now because, you know, he sneezed and busted a blood vessel in his brain, had a brain bleed. We didn't have the medicine. We know 2 weeks in the hospital, but now my son can go whatever. We don't really have it, but I mean, it's just having access to care, but it's also people like you who are taking the time to listen and to help us understand and help us find a way. That's all we want to do. We're not trying to be demanding. We just want to work together to find the best solution for everybody involved.
Yeah, and it's your son who's he's working. He's an inspiration.
Yeah.
So here's what let's end it on this. Y'all, let us hear. You got more power in your voice, you know, than you think. I have, you know, and as I mentioned to Colette, I have so many people that come in and say, and I'll use a car analogy, I need my car fixed. Well, what about your car? Is it Is it not running? Is it the brake? No, I just need my car fixed. No, you got to break it down. Do me a favor. Let's break this thing down and let's go at it, because I'm very worried about groups like yours with the cuts that are going to be cut anywhere from 70 to 80% in the coming months and years. Let's find a cure for it. I'll help you, and I really appreciate y'all.
Thank you.
Take the time.
Thank you. Thank you so much for your time. We will be in touch. We will do our due diligence on our side, I promise. And we'll bring in the rest of South Carolina, Lindsey Graham, and everybody else in, and let's find a solution, because I think if we all work together, we'll get it done. So thank you so much. I appreciate your time. And we'll let you go. And if the group want to stay on for a minute, let's give them a clap and give them a
thank you
for being with us. It was just a pleasure. Really appreciate
Thank you so much.
All right. Thank you. Bye-bye.
Thank you. Bye-bye.
All right. Well, was that not wonderful, guys? Go ahead and unmute yourself.
Yes.
Greg, stop highlighting so we can see the group. If we can. I think we still got Colette highlighted there.
Yeah.
No, I got somebody else. How do we get everybody back to gallery view? Oh, there we are. So now I can take a picture. Let me take a picture of y'all.
Oh gosh, you took a picture. Cool.
So I should take one. Everybody put your cameras on.
Come on here for a picture.
Everybody put your cameras on. And look pretty. Ready? Jeremy, look up. All right, here we go. Oops, it didn't go. Hang on a minute. Okay, here we go.
Hi, Sue.
Yes. Let me get the rest of the group. Hang on. All right.
I know it's weird.
Number 2, let's get all of you guys. Undo yourself so we can see you. Oh, wait a minute. Why did that not work? Let's put that back. Let's try this again. Oh. Hang on one more minute.
Good job.
There we go.
And then when she pushes out the media stuff on their
Was that not good? Do we not have work to do, guys? Colette,
Sure
have
do.
a good time in Washington. We'll come with you. Way to go. Way to go. But you guys, I cannot thank you. There's 36 of you on here. I know you have your families, but really seriously, we need to find solutions. We need to all be at the table, or now we're going to be all at the screen. If you have anybody else that you can ask to join us, we'll do this again. We'll just keep doing it. We'll make a difference and find a solution, because there is no.
Ooh, I got
make this
cuts on my fingers. Oops.
Colette and Nathan.
Forgot I wasn't muted.
Everybody, Kimberly, all of you, we can get this done, because what he said made me really nervous about the cuts, and us being a small group and a small group. We need to be a very loud, the right way, but we need to be a loud group so that they really understand, and our group doesn't get the cuts because we're smaller and it doesn't affect as many people. We need to be twice as stronger than everybody else. And every group that can do it, it's this group. That I do know.